Hello everybody, this is me, Dr. Sergio Rovinski from Shoulder Planet, here from São Paulo, Brazil. I am very honored to be participating here from Wiroc, this lovely meeting organized by BOSS, Bombay Orthopedic Society, and I invite you to see all of the videos that I have sent to this wonderful meeting and to learn the most you can with them. And if you have any doubt, don't hesitate in sending me an email. My email is sergio@shoulderplanet.com.br. I thank all of the organization of this lovely meeting, and I hope you have fun seeing all my videos, and Dhanyavad. Shoulder Planet presents supraspinatur pasta lesion double row repair, another educational video for our friends orthopedic surgeons from me, Dr. Sergio Rovinski. Supraspinatur pasta lesions are common problems in every shoulder surgeon's office, and their management depends, including other factors, on the thickness of the tear. The term pasta means partial articular supraspinatus tendon lesion or tendon avulsion. Usually, if the tear has less than 50% of the tendon thickness, conservative management is indicated, and on the other hand, if the tear involves more than 50% of the tendon thickness, surgery is usually a tendency. These lesions occur generally in younger patients, and they really ache a lot. So here I'm presenting a case from a 47-year-old man who does not play sports and who started to have a very typical subacromial symptoms in his left shoulder in July 2011. Here we see his MRI revealing a very typical anterior supraspinatus pasta lesion in which we can see that the tear involves more than 50% of the tendon thickness. I told him at that moment, in the beginning of the treatment, that we would try conservative management initially before going directly to surgery. So we performed in October 2011 a subacromial injection in his left shoulder. The patient really did evolve very well with absolutely no pain in his left shoulder, and 2 weeks after that injection we started some strengthening rotator cuff exercise in his home, and he started some physical therapy too. So the patient did very well for about 3 months, but in February 2012, in the beginning of this year, his pain was back again. So I suggested him about surgery, but the patient strongly insisted to receive a second injection, a second shot. So we did it in February 2012, and the patient did again very nice, and he stayed pain-free for about a month. But then in March this year, the pain came back again, and after that an arthroscopy was indicated, and the patient was operated in July 2012. So this is his arthroscopy. Here we see a left shoulder, we see the biceps and the biceps anchor. The biceps was quite ugly, so we decided to perform a biceps tenotomy and maybe a tenodesis, but first we would have to perform a whip stitch. So now we are doing the whip stitch in a very classical fashion and passing a Prolene through the biceps and pulling it out of the shoulder through the anterior portal. Then with an arthroscopic scissor we started the biceps tenotomy that was done in a very fast manner, and it's a very simple procedure. We ended the biceps tenotomy with a simple soft tissue shaver, and now we can see that the biceps is tenotomized and stuck in the biceps pulley. So we took a very fast analysis of the subscap that was pretty okay, and then we saw the pasta lesion. So here we can see the pasta lesion, very typical, and then we entered with a shaver for the the articular part of the shoulder. We tried to complete the tear. It was very hard because we didn't have much space. So then we immediately moved to the subacromial space. We have to perform a formal bursectomy. Small tears like this always have a huge bursa, so we would have to debride all that bursal tissue until we started to find the inferior surface of the acromion. Now we can see the inferior surface of the acromion with very typical arthroscopic findings of impingement with fraying. And here we can see the lateral gutter and the anterolateral gutter also. So we used a shaver to clear the lateral gutter, and here we have to find the anterolateral corner of the acromion to know where we are. Until we see the deltoid, now we can see the anterolateral corner, and we so continued with the shaver to create a space, to create a view, and to clean the lateral gutter as we have seen here. So at that moment we changed the portals, and now working with the shaver for the posterior portal, we continued to clean the anterior gutter. It's very important to say that in these cases with very small anterior tears, we have to clean the lateral and the anterior gutters very well, and this is what we are doing now. So after that we saw the tear. Here we can see a very small tear with the biceps inside it, a very anterior tear, and then using a spinal needle we established an anterior supralateral portal that we would use to manipulate the lesion and to pass the anchors. So we entered with the soft tissue shaver, we started to debride all the pathologic tissue, and we started to complete the tear, and that can be done with the soft tissue shaver and with electrocautery, as we are doing here, not only to create space but also to prepare a bony bed in the greater tuberosity in which we would fix the tendon. So then we changed the portals again, and now we are working for the posterior portal to perform a very simple and fast acromioplasty. This is a procedure that shall not take more than 3 or 5 minutes, and this is what we are doing now. And here we can see that the acromioplasty is finished, and then we changed the portals again. Now the camera is in the lateral portal, and for the posterior portal we are just ablating the superior fibers of the tendon. And now for the anterior superlateral portal we are putting the first anchor, the medial one, since we wanted to perform a double row suture repair. Once the anchor was put, this is a 5.0 double-loaded metallic anchor, we enter it with a grasper for the anterior superlateral portal. We grasped a healthy bite, but very gently, of the tear of the tendon. And for the posterior portal, we enter it with a spectrum device, and we passed the proline suture that was just put out of the shoulder with a simple grasper for the anterior superlateral portal. And then in a retrograde fashion we would pass the posterior leg of the medial row suture, and then we unloaded the white one, since we just wanted one suture in the medial anchor, and we would have to pass another proline. But now for the anterior portal, and this is what we are doing now. So the proline was grasped again and put it out of the shoulder for the anterior superlateral portal, and then in a retrograde fashion the anterior leg of the medial row was passed through that tendon. Then we would have to put a second anchor, a more lateral one, to perform the lateral row sutures. But first, for the anterior portal, we isolated the sutures. This is something we think is very important because we don't want to make a mess with the sutures. And then with the white one isolated in the anterior portal that was being used as a waiting portal, with an expressive device, we passed the posterior lateral row suture, and that one was grasped out of the shoulder for the posterior portal. And then we would have to pass both legs of that posterior lateral row suture out of the anterior superlateral portal and tie that knot. So now we are tying the posterior lateral row knot, putting in a lot of pressure in order for the tendon to heal in the bony bed that we had just created. And once the stitch was done, we would just have to cut it. So then the suture was cut, the knot was cut, and we would have to put both wide sutures through the anterior superlateral cannula and pass again with an expressive device the anterior lateral row suture. So now we are passing with an expressive the anterior lateral suture, and we would have to put that out of the shoulder now with a grasper through the anterior portal, and then pass and tie the second lateral row suture, the anterior ones. So with a suture manipulator, we put both legs of the white one out of the shoulder when we tie the second knot. So now the lateral row is done and fixed. So now that the lateral row was done, we would just have to pick both legs of the medial row suture. First the posterior one as we internally rotate the shoulder, and after that the anterior one as we externally rotate the shoulder to tie the medial row knot. So now we are tying through the anterior superlateral portal, the anterior superlateral cannula, the medial row, and once the knot was tied, it would just have to be cut. And this is the final image, the final construct. Here we can see the lateral row, the medial row, and with a very good reattachment of the footprint as we look upon the subacromial space. We can see here the acromioplasty that was very nice, and back again looking down, we can see the final image. Here we can see the lateral row and the medial row, and at that moment the surgery was then finished with a very good reconstruction of the footprint.